Good evening, everyone. So today we are here with the 35th webinar of FSIVC series, and we have chosen two very important topics of breast cancer radiation therapy, which are ultra hypofractionation and motion management in breast cancer. We'll start with the welcome address, and for that I would like to invite Dr. Dinesh Singh, Sir is Chairman Radiation Oncology at Andromeda Hospital, Kundli, Sonipat. Over to you, sir.
Good evening. Thank you, Dr. Prekshi, and I welcome all the faculty and all the delegates who are logged into this 35th edition of our focused studies in breast cancer. And we have been taking very select topics, and then we go delve deep into those topics to threadbare them. This time we thought of discussing about the ultra hypofractionation radiotherapy in breast cancer. Well, it has been taken up as a standard of care in the UK, and in many other centers, it is gradually becoming a standard of care and work in progress in many other institutions. So what are the nuances about it, and is it the time to jump onto this that we will be discussing today? And Dr. Punita is there to throw lights on that. Then we will having a discussion on the motion management in breast cancer, which is also a very important and very critical area to save those to the heart and lung and long-term morbidities. And then we will be having a panel discussion in which we will be going into details of all these aspects. So I welcome all of you, and I hand it over back to Dr. Prekshi for further proceedings.
Thank you, sir. I want to convey one thing that due to some unforeseen reasons, some of our panelists are not able to join today. So there's a little bit of change in the program. After both the talks, we'll have the discussion, we'll merge the panel discussion after the talks itself. So after ultra hypo talk, we'll have the panel discussion regarding this topic, and then after second session. So for the first session, which is ultra hypofractionation schedule in breast cancer, I would now like to invite Dr. Punita Lal ma'am. She is professor and head, Department of Radiation Therapy, SGPGI, Lucknow. Over to you, ma'am.
Thank you, Prekshi. Can I share my slides as well?
Yes, ma'am. You can share.
Okay. Right. Is it visible?
Yes, ma'am.
Yes, just put it full screen, ma'am.
Yeah, that's what I'm trying to do. Genuine. Is it all right now?
Yes.
Yes, ma'am.
Yeah. So once again, good evening, everybody. Thank you very much for inviting me. Prekshi has been the face, and I've been talking in dialogue with her. But I think there are a lot of people I have to thank. This webinar series group that you have designed, and you do it so studiously. This is my second opportunity that you have given me. Thank you very much. And the IACT group, Andromeda Hospital, all of you, and seeing old friends has been very nice. Thank you so much. So let me begin without any ado about the ultra hypofractionation. Actually, I kind of modified it back to hypofractionation because I thought the story would be incomplete if I just talk about ultra hypofractionation without taking the story forward from the beginning. So let me just start. As far as we all know, that radiotherapy in breast cancer is there to stay. It's shown survival benefit, and for every 4 patients that we improve our prevent locoregional recurrences, we save 1 life. So there is a survival benefit. And age-old practice has been to give conventional radiotherapy, and because the tumor has already been removed, so 50 grays in 25 fractions over 5 weeks has been sufficient. Why did we feel the need to shift to hyperfractionation? But before I go on to that, let me just start again about conventional fractionation. So in our initial understanding and knowledge was that breast cancer tissue behaves like a mucosa or an early reacting tissue. So its alpha beta was 6 to 10. That was an assumption that we were working on, and therefore we said that 2 grays per fraction is what we would be giving, and hence we settle on the dose of 50 gray in 25 fractions over 5 weeks. And it showed its set of acute reactions, late consequential and late reactions that we got to see. Again, the question comes up, why we wanted to shift? Well, radiobiological experiments showed us that it is the alpha beta ratio in a cell survival curve which determines the fractionation sensitivity. If the alpha beta is less, the fraction sensitivity is high, which means if you change any change in fraction size is going to make a marked change in the tumor control probability. If you increase the dose per fraction, there would be a remarkable increase in the tumor cell kill. So these initial experiments, the radiobiological workers felt that we were actually, the breast cancer alpha beta was something like 3 to 5. They were not very sure. And this was much lower than, say, head and neck or skin, and like other tissues as well. Of course, it did not match with the brachial plexus. So the radiobiological rationale was, like I said, alpha beta, if it is less, which it is in breast cancer tissue, it is a slowly reacting tissue, just like prostate, and therefore has a high fractionation sensitivity. And therefore, it is assumed, it is reasonable to sort of logically state that hypofractionation it could be efficacious in breast cancers. Provided, so it would be safe and efficacious provided we make the downward adjustment of the total dose. Then there was also this issue that workers started looking into that if we are dealing with 5 weeks, or actually along with boost, it becomes 6 to 7 weeks. So these protracted extended fractionation regimens ensured that there was some bit of accelerated repopulation, which was counterproductive towards the tumor cell kill. If we look into all these factors, then we might have something that is equi-efficacious as far as the oncological outcomes are concerned, with good cosmesis, with convenience, with less toxicity and everything. So like I said, hypofractionation, our initial understanding was very poor. So it has had a checkered past. Why do we say that? Because in terms of clinically, the patients had more number of brachial plexopathies were seen whenever people had done hypofractionation studies in breast. Skin reactions were unacceptable and permanent, rib fractures were there, and all this was due to a variety of reasons. The beam energy was not good, the beam technique was not good, they were non-isocentric techniques, so the patient would have to be shifted during treatment. Some patients earlier would be treated on alternate days. That was another bad way of treating. And they did not make dose reduction positioning, like they were sometimes overlapping field between supraclavicular region and the bitangential region. So those were the issues that were plaguing us. Then came our understanding grew, and we realized that with a sound rationale, we probably could be more successful in hypofractionation, which meant that we took the fraction size to beyond 2.25 gray per day, reduced the total dose, maybe looked into shortening of overall treatment time, used better infrastructure and technology, and of course, the techniques should be superior and precise too. So the clinical benefits would be that the cost would reduce for the patient. There are fewer number of fractions. It would be so much more convenient for the patient to come for a couple of weeks than, say, for 1.5 months or so. Ease of travel and lodging and compliance would be better. So that would also affect the results. From the hospital's point of view, increased throughput, more patients will have access to healthcare, and the academically radiological understanding would improve. Of course, these were not without concerns, because late toxicity, cosmesis, local regional control, all were being asked at that point in time, that what is going to happen to them. This was the genesis where the landscape of the START group of trials was started on, where they started giving they reduced the fraction size modestly, and which is what we saw. Now, this started because the assumption became from say 6 to 10, the breast cancer tissue alpha beta became, it was understood that it was somewhere between 3 to 4 gray possible, which meant that you could bring the dose per fraction from just 1.8 to 2 gray to 2 to 3 grays per fraction. Dose per fraction would increase, number of fractions was to be decreased, and the total dose was also to be decreased, provided we kept the overall treatment time same. So that was the start of the START pilot and START 8 trial, where they used two fraction sizes. They studied two fraction sizes, that was 39 gray in 13 fraction and over 5 weeks. The important thing to remember is 5 weeks, and 41.6 gray in 13 fraction over 5 weeks again. This was compared with 50 gray in 25 fractions over 5 weeks. We'll talk about double trouble and triple trouble subsequently. So these were the trials that were started in the UK. Canada also was doing similar trials in invasive breast cancer, which was more or less early disease, had zero or no nodal or low nodal burden, and eventually they came up with their 10-year results also. They studied both the breast cosmesis point of view and the local relapse point of view. What they saw was that when you gave 41.6 or 39 gray, you had breast induration or shrinkage, which was not more, but maybe a shade lesser than 50 gray in 25 fraction, which was to our advantage, like 34 gray were as against 31 and 30 gray. Similarly, they also saw that local relapse also, if you see, so if it was 6.7% at 10 years for 50 gray in 25 fraction, it was 5.6 in 41.6 gray. However, it was also seen that in 39 gray, because the dose was a shade less, the local relapses were a shade more, which was again not very acceptable. And so therefore, it was 41.6 that was more acceptable than 39 gray. And if we look at the time trends and the Kaplan graph, we see that 41.6 was the figure that was simulating the 50 gray in 25 fraction, but 39 gray was a bit on the higher side. So that was the reason why it was something that was around 41.6 that stayed at least with the Canadians. Now came the factor that they said, okay, we've studied hypofractionation. Shall we add acceleration? Shall we accelerate it a bit and take care of the time factor, because of which accelerated repopulation would occur, and there would be a loss of 0.6 gray per day if we do not accelerate. So let's work on that as well. What they did was, again, the fraction size was above of 2 gray, increased the dose per fraction, decreased the number of fractions, decreased the total dose, and also decreased the overall treatment time. This time in START B, so from 41.6, they made it to 40, made it a little more gentler, and 40 gray in 15 fraction over 3 weeks, that is 5 fractions a week. This was modest acceleration. Again, the assumption was that we are probably having an alpha beta in breast cancer to the tune of 3 to 4 gray. This was also an approximation based on the experiments, but that's what they thought. Possibly it is that. So that was the genesis of START B trial. They presented their 10-year results, and they showed that in terms of breast cosmesis, 40 gray was not inferior. If at all, it was shade better than 50 gray. Similarly, if we look at the locoregional tumor relapse, 40 gray was not inferior. In fact, it may have been a shade better. So that was what set the stage, and 3-week treatment became the standard of care. Today, worldwide, 40 gray in 15 fractions or 41.6 as the Canadian do it, for 41.6 gray in 16 fractions is the standard of care. But I did mention about the double trouble and triple trouble. This was an issue in hypofractionation, whenever we saw. We saw this in cases wherever there was a hotspot. The larger the hotspot, you can expect that the dose deposition would be more. So that means higher total dose would reach that hotspot region at higher dose per fraction. And the larger it was the proportion was disproportionately high, and therefore the hotspot got penalized much more severely than what you would get in when you were giving conventional fractionation. So the bottom line became that instead of 95 to 107, the ICRU itself said that in hypofractionation, maybe we should look at 95 to 105% and keep the hotspots minimal. That is the bottom line. And the conclusions from START trial, group of trials, was that they had very lax and broad eligibility criteria, but it was a predominantly early disease with no nodal burden or low nodal burden. And they felt that 40 gray in 15 fraction, based on the UK practice, should be considered as the standard schedule. There was no need for us to give more than 15 fractions for the breast or the chest wall or the lymph nodes. And they also mentioned that 2 gray is probably too gentle for the breast cancer cells. No point giving that. The only thing that one looks into the papers deeply is that there were certain underrepresented groups, and those needed to be studied further. Like, for instance, very heavy breast, very bulky patient, or a high nodal burden in the axilla, and things like that. So those needed to be studied. The other question, when we change gears, we see the researchers felt was that we actually have probably not reached to the limits of hypofractionation. Probably 15 to 16 was not the limit of hypofractionation, and probably alpha beta was not between 3 to 4 or 4.6, but it was something like 2 to 3. And that is what they started working on. This is what brought on the genesis of ultra hypofraction. Here again, they said, okay, we will look into the hypofractionation part of it first, and then we will talk about the overall treatment time or the time factor. So, like I said, alpha beta 2 to 3 gray was the approximation this time, and they said, okay, from 2.67 grays, we increase it to say 5 or 6 grays per fraction. So the dose per fraction was increased significantly. Number of fractions were decreased significantly, and total dose was also decreased further. From 40 gray, now the FAST trial group started, and they compared 30 gray in 5 fractions over 5 weeks. Remember, 5 weeks, and 28.5 gray in 5 fractions over 5 weeks were the two experimental ultra hypo schedules. They were compared with 50 gray in 25 fractions over 5 weeks. Now, why one could ask this question, why were they doing 30 gray and 28.5 gray? Why 40 gray, 41 gray and 39 gray? Because, like I said, fractionation sensitivity, when it is very high, so between two fractions, story completely can change. So they were looking into a very narrow range and trying to find what is it that is clicking, which is the best with better cosmesis, less toxicity, and equal results, outcomes. So that was FAST trial again from the UK. Like I said, they compared these 3 arms, and in this, they said they looked at the photographic appearance of the breast. That is, they were looking at the cosmesis component, and they found that between 30 and 28.5, it was 28.5, which was simulating the 50 gray, not the 30 gray. 30 gray, the cosmesis was worse, as significantly more, and there were major breast induration and shrinkage that were seen. And so they chose that probably 28.5 gray in fast trials is a better answer. And in terms of the results, well, the outcomes 30 and 28.5 were similar, almost similar, and a shade lesser than the 50 gray. When you looked at the relapses in terms of numbers, they found that 30 and 28.5 had, well, almost similar relapses, not at least not significantly different. And the regional relapses also, 28.5 had a little more than 30 gray. So that was what they came up. The conclusions from the FAST trial was that adverse events were not very common, and 28.5 gray in 5 fractions over 5 weeks actually behaved like 50 gray in 25 fractions. And like I said, AEs were similar, and they said that you could consider once a week fraction, 5 fraction schedule may be considered in patients where daily fractions was not possible. Then came, they said, now we shall look into the acceleration component also, add acceleration like they did in the START trial. And so came the fast forward, where they added ultra hypofractionation along with acceleration, took into account the time factor. Again, the assumption was that alpha beta is somewhere 2 to 3, and we would give over of 5 gray dose per fraction, increase the dose per fraction, decrease the number of fraction, decrease the total of dose, and decrease the overall treatment time. This time, they had an even narrower range to compare, because now they've done acceleration also. So they reduced the dose from 30 and 28.5 to 27 and 26, and then studied it. So that was the ultra hypofractionation schedule. This they studied with 3-week tool. That is by which time, because 40 gray in 15 fraction had become standard of care. So 2.67 gray was compared to 5.4 gray versus 5.2 gray dose per fraction. They published their results, and with the primary endpoint as ipsilateral breast tumor relapse rate, and they had over 4,000 patients. And what they showed was that, actually speaking, the 40 gray and 27 gray in 5 fractions were similar, and 26 was a little lesser, in fact, in terms of breast tumor relapse. And if we look at the cosmesis part of it, so they looked at the marked changes, and they found that 40 gray showed 0.5% of the tumors having, the breast having marked change, which was 5% in 27 gray and 3% in 26 gray. That's why, because normal tissue effects were safer and it was non-inferior in terms of statistical significance, 26 gray became the standard. So they looked into the fact that what was it that both had adverse events which are not unacceptable. So what was it that 27 gray in 5 fraction behaving like? It was behaving like 50 gray in 25 fractions. What was it that 26 gray in 5 fraction was behaving like? It was behaving like 40 gray in 15 fractions over 3 weeks, which is like 46 gray in 23 fractions over 4.5 weeks by conventional fractionation. But because of taking care of accelerated repopulation, you could get away with that instead of going up to 50 gray by conventional fractionation. So of course, we still await mature follow-up data. There are a lot of concerns. Cardiac issues have been, concerns have been raised, but then they are equal for any fraction. We have to be concerned at all cost. So that, because now we realize in the West, in where the screen detected cancers are there, 26 grain 5 fraction in early screen detected cancer, mostly early screen detected cancer is becoming more and more standard. We should look into our data, our patient profile, and as a multicentric study, we have which we have been doing since 2020, late 2020 or 2021, the Hypot adjuvant, which is between 3 or 4 centers like TMC Kolkata, CMC Vellore, RAS and all. So we have accrued almost these many patients, 2,100 patients, and looking into local regional relapse. The difference between our study and the fast forward trial is that we have just one. We are comparing 40 gray, 15 fraction, 3 weekly versus 26 gray, 5 fractions, 5 day, because we have the data that 26 gray is the one that is more or less acceptable. And also because we wanted to look into the profile, our patient profile, where the tumor burden is more, where our work throughput is so much more, that quality is can be, we can just use the benchmark quality. So that is what we have done. And all, we have taken non-metastatic disease in all cases for this trial. And this is the protocol. Now, not only us, there are other workers also. PGI Chandigarh in last month or so has published in Lancet Global Asia, and 1,100 patients, 2 weeks versus 3 weeks. They've given, of course, so far the acute toxicity profile, which is no different. And they've used both LINAC and Cobalt and used 2D versus 3D. So it's a good trial to look at. Similarly, there are other people who have looked into and found that ultra hypofractionated radiotherapy of fast forward type has comparable toxicity, tumor control, but they do mention their concerns regarding regional nodal irradiation, especially the IMN, the boost, we still don't know, especially in the era of oncoplasty. Reconstructed breast, we still don't have the answers. Other histologies, we don't have the answer. So, I mean, using caution, people say that ultra hypofractionation is a preferred thing, but at the moment we can state with confidence that it is comparable in low risk situations. We still have to talk about its generalizability to the garden variety, especially the kinds we see. The toxicity remains comparable, but we have to be now our understanding of OARs has increased. So we have to meet the dose constraints, and then only we need to move forward in these cases. Coming to the last bit, and that is the single fraction, because there are people who believe that no, it is not, alpha beta is not 2 to 3, it's probably 1.5 to 2. We don't know. People are working on it. So they've increased there are trials which have increased the dose per fraction. They've given 21 grain single fraction, decreased the number of fraction to 1, total dose to 21, and overall treatment time, of course, 1 day, because they felt that reoxygenation is not required, anti-tumor immunity kicks in, and a lot of things which are still under study. People have used SABR also, people have used SPRT, but these are all anecdotal reports, and we still cannot say. So all one can say in the end is that last has not been said, but what we can say is that these ultra hypofractionation protocols are logistically very attractive. And we feel that radiobiologically speaking, 5 fraction appears to be the limit of hypofractionation so far. Let's see what happens. We cannot decide our practice based on the screen detected cancers. So we wait for the results which belong to our patients. And we must understand that there would be extrapolating and generalizing the entire issue may become counterproductive. We should look at the underrepresented subgroups with a different lens altogether and see what we can do best for them. The bottom line is that infrastructure, dosimetry, QA become all important, and we have to keep hotspots minimum in these abbreviated schedules, because triple trouble can be very, very nasty. And we, of course, need longer follow-up before we can say that this is the standard of care. So I'd like to wind up. I'd like to acknowledge the entire breast team at SGPGI. In fact, our hypot adjuvant team and the patients who have reposed a lot of faith in us while during this treatment. So thank you very much. And if there are any questions, I'll be happy to take.
Thank you, ma'am. That was a great talk. First of all, I request you to please stay for the discussion part also, which is going to happen just after your talk only. Can I see the slides, please, Neera? For the panelists?
Sorry?
Yeah, so like I said, there is a bit of change in the program, and we are now discussing the ultra hypo part right now, followed by the session 2, and then discussion of that topic. So it will be, I'll be just asking the questions, and I'd like to invite the panelists. Punita ma'am, please stay for this part also. Dr. Sweeti Gupta ma'am is additional professor, radiation oncology at AIIMS Rishikesh. Dr. Gagan Saini, sir, is senior director, Radiation Oncology, Max Vaishali and Patparganj. Dr. Aanchal, she is consultant, Radiation Oncology, Patel Hospital, Jalandhar. Dr. Rishabh is not, he has not joined due to some reasons. Let us now discuss some practical nuances and some challenges which we face, or rather we will face if we practice ultra hypo in our clinical day-by-day routine. So let us consider an example of a woman who is 65 years of age. She is clinically T2 and 0, ERPR positive, biopsy proven, ERPR positive, HER2 negative. She is diabetic, hypertensive. This woman undergoes surgery, breast conservation surgery, and the pathological stage is T2, sentinel nodes negative. Her oncotype DX was done and it was 29. So she received chemotherapy. And after completion of chemotherapy, now she is presenting to radiation department. So I would like to ask Sweetie ma'am, what will be your prescription, radiation prescription for this patient? Ma'am, you are mute.
Yeah, thank you, Dr. Prekshi. Basically, this is a postmenopausal female who is a liminal A, pathologically T2, node negative. Her laterality is left breast or right?
It is left breast, ma'am.
So she is a case of left breast liminal A postmenopausal patient. As ma'am has also already discussed about hypofractionation and ultra hypofractionation. For this patient, I will advise a hypofractionation for this patient. 40 gray 15 fractions over 3 weeks.
Okay. So does anyone differ, Gagan sir, Dr. Aanchal, would your prescription be same with moderate hypofractionation, or would you like to consider ultra hypo in this case? Dr. Aanchal, you're mute.
Moderate hyperfractionation, 40 grain, 15 fraction.
Yeah, your take, Dr. Gagan?
Oh, okay. Am I okay? So, firstly, thank you, Prekshi, and very nice presentation by Dr. Punita, ma'am. So, okay, so I would only differ a little bit because I would like to give boost as well to this patient. What was the age, sorry, for this patient?
65.
65. Yeah, I would still like to give some boost. That's all is the difference. So hypofractionation is fine for a patient like this. I would give some boost, that's all.
Right. So now let us discuss about ultra hypo. Does age matters when we decide the radiation, like is it moderate? So whether you are not going to subject a young patient to ultra hypo, or you are considering an elderly patient who is difficult. So does age play a role in that? Punita ma'am, what is your take?
I wouldn't say that. I would say,
Okay.
see, and if to answer your first question, because we are committed to a trial, so we would randomize it, and this is a part of our randomization. If it was 65, T2N0, ER positive, diabetic, hypertensive, I would go ahead and treat her with whatever, whether she falls into the hypofractionation or ultra hypofractionation irrespective. Now, I would agree with Gagan that yes, boost is something that really needs, I mean, we would give whatever our understanding, even though our surgeons are very keen on oncoplasty and we find it very difficult to give boost in these patients because the cavities become bigger, but we would also give. The other two things that I would do is that if the breast was heavy, I would look into the breast board. Otherwise, if it is a small breast, I would look into the wing board for patient positioning. DIBH was the other thing that I would like to focus on. So, and what was your second part of the question? I'm sorry.
So
You
basically, ma'am, I was asking whether age is a criteria to subject any patient to ultra hypofractionation or just to disregard this
no.
schedule in that. The age is not a criteria. Basically, that was.
It is
Ma'am, can I ask you a
designed for,
question?
yes,
Ma'am, Punita, ma'am, I'm
Yes.
building on the question Dr. Prekshi is asking.
yes,
Ma'am, if it is a young patient, say 41 or 42, same thing, T2N0, everything is the same. This is
yes,
a patient where regional nodal irradiation is very relevant.
yes.
Now, ma'am, please tell me, would you like to consider ultra hypofractionation for this patient? Because, ma'am,
Yes.
and ma'am, this is not a question to just to bring some twist in the discussion. I really want to understand this part
Yes.
since you are doing this trial. The second thing which you will probably address in this same answer is, which I want you to pay a little more this thing to, is that when we are doing regional nodal irradiation, ma'am, then the tissues that are getting irradiated are the neck tissues. Their alpha by beta is not 5 or 2 or 3 or whatever, 1. So what is happening over there? So so what is your take when you are actually doing it? How do you take decisions?
Yes. So a very good question, because we also had this fear, a lot of this fear, especially going by the past sort of stories of hypofractionation and all. What we have, see, over a period of time, our understanding of OARs has also increased, and all of us are using CT data set and all. So for every single patient where a regional nodal irradiation, if we have to treat the supraclav and all, we we draw the brachial plexus and we look into the dose constraints of that. It should never exceed the 100% tolerance. We keep it under that, and then we are safe. That is what the radiobiological data is, because brachial plexus, the alpha beta is around 2, right? So that is one thing. Second thing, your question was about the neck tissue, that they are not 4 or 3 or whatever. Very true. And therefore, sometimes we feel that the reaction, it's too early for us to say because we haven't analyzed the result. But yes, sometimes their swallowing is a little more. And as far as we are concerned, our trial does not allow us to say that, okay, if it is if the nodes are present, you will not include it. We will include it because that is what we are seeing based on the subset of the fast forward and other trials, that we can include the node positive disease to include supraclavicular disease, provided we meet the tolerance of the brachial plexus, the lung, the heart, and all of that we have to see, and we do not go into the contralateral region, breast.
Ma'am, all these trials which have actually proven the benefit of ultra hypofractionation, were they treating the neck nodes actually, or were they only treating the breast, ma'am?
No, they were not N0 neck, but predominantly they were N0. They were not only N0.
So, ma'am, they were not treating the neck, right? Or
No,
they were?
they
In
had
fast forward,
in a small
For some patients.
for
Ji,
some.
ji. For some. So,
So in
ma'am,
the initial design,
this is
yes.
definitely a gray area, ma'am, in that case, because our patients would always need some radiation to
Yes.
at least the SCF for all practical purposes.
So,
Ji,
see,
ji.
yes, a gray area to that extent. But what is the fear? The fear is brachial plexopathy. Now, brachial plexopathy, that much of studies have come up that brachial, yes, that if you do not exceed a certain dose, you are okay. That you have.
Ma'am, I'm not worried about brachial plexopathy at 26 and 5 because that's a dose we are doing left, right, and center. I mean, maybe we should be worried in the sense that we should be careful, but that's not probably something very commonly that will happen. I'm worried more about cosmesis to these tissues of neck. So because the cosmesis is a very important part of breast. So the cosmesis of breast is fine. But when we are going to have contractures of the neck and those sort of things, wouldn't that be a problem? And this is just to build the discussion further. Also,
Yes,
ma'am,
yes.
I feel that the hypofractionated radiation of these axillary vessels will make them more liable for embolic episodes, with thromboembolic episodes, ma'am. This is my submission, because in head and neck we have this experience that when these glottic cancer patients, they survive for long, then the chances of them getting these embolic events significantly increase. There's a statistically significant increase. Multiple studies show that. So I'm just thinking out loud, ma'am. At the end of the day,
Yes.
when we are empirical, we are empirical. But I'm just thinking out loud, because you are a very
We're not
knowledgeable
being
person on this.
empirical. No, not like that. We're not being empirical. The data is, all this is based on lot of background data. But one thing about the cosmesis, see, I will not be able to tell you until we come up with the final results. But offhand, we are not encountering excessive toxicity in terms of cosmesis. As far as your embolic is concerned, that is always a concern. That may be a little more, and that will only appear 10 year or
10 years
something
later.
down the line. You are very rightfully pointing out the glottic data, because there, instead of what we do parotid sparing, people have done carotid sparing and seen. Of course, at the moment, there's nothing to suggest that that should be the standard of care, but there is an apprehension, and rightfully so. I have no answer to that.
Dr. Punita, have you ever irradiated the axilla also? Because in some patients with heavy node positivity or extra nodal spread is there. So have you
Yes.
ever
Yes.
done that?
We've taken, because we have such patients that occasionally an axilla, very occasionally, but we have. And we discussed it in our multicentric trial that this is the patient. And so after going through, we have, because again, apart from, it hasn't increased the lymphedema to that extent that I should say that we should stop. And ultimately, the worst thing that we can do is to give a tumor recurrence. So either we had a choice of not including the patient in the study,
Right.
or including after discussion, in which we have done.
Okay.
So, ma'am, after complete axillary lymph node dissection, you have used this
No. Only in very
non-dissected,
rare situations, yes,
undissected
sentinel node
Undissected or
was,
partially
yes,
resected.
yes.
Okay.
So now I would like to ask the question whether the breast laterality, whether it is right side or left side, or the breast size, suppose in bulky breast, do you see any increased acute toxicity in such cases? Are you comfortable using ultra hyposchedule in very bulky breast? Or suppose the tumor is located in the bulky breast with tumor in the inferior quadrant in the inframammary fold. So is it fine to go ahead with ultra hypo?
Yeah, see, it's absolutely fine. In very bulky breasts, we have not published our acute toxicity data as yet, but Buddhi Singh Yadav has, and he is fine by it. That's his data that speaks. For us in bulky breasts, the problem is the how to contain these hotspots, which is a very big problem, which we are finding it difficult at times. So those are the cases. Sometimes we say, no, we will not subject them. We'll subject them to 40 grade 50. They are outside the protocol. When we are unable to contain, I mean, going up to, we try to restrict to 105. We are unable to do that. So but we start seeing from 105%. We don't start seeing from 107. 107 तक आ रहा है या उसके अराउंड आ रहा है तो we'll accept. We say कि okay 105 पे कितना है, 6 पे कितना है, 7 पे कितना है. But 8, 9, 9 तो हमारी, unless it's a point dose.
Yeah.
So chest wall, is it fine to go ahead, or like only the BCS cases? So chest wall, is anybody using this ultra hyposchedule in
It's so
PMRT?
all non-metastatic we are using. So it's for chest wall also 40%, 60% of our load is probably
And what about bolus, ma'am? So are you using bolus daily?
daily. We are using daily. And we have, because Tata has published their results long time back, Rajiv Sareen, that around the scar, 3 centimeter above and 3 centimeter below is the highest risk of recurrence. So we make that kind of a bolus.
Sweetie ma'am, are you practicing ultra hypo schedule in your patients? Ma'am, you are
No,
mute.
Dr. Prekshi, no, Dr. Prekshi, we are only practicing moderate hypofractionation. And as ma'am has rightly said, even in moderate hypofractionation, we are facing in bulky breast the problems of hotspots and acute reactions, mainly in the inframammary folds. That is the problem. But as of now, we are not using ultra hypofractionation. We are done only in 2 patients during the COVID times, but they fared well. But that is a very small data, I can say. It's 2 patients only.
Dr. Gagan, I would like to ask you, what is your take on patients who undergo reconstruction? So those patients who undergo reconstruction, is it fine? What is the tolerance of the flap tissue if we go ahead with ultra hypo schedule?
I would only say a couple of things. When I was asking Dr. Punita about all these things, then ma'am was very graciously answering all these nice questions. So I'll probably make those points again. See, whatever the entire buildup of hypofractionation for breast was based upon cosmesis and alpha beta of the breast. Now, when we start treating these non-breast tissues with hypofractionation, we are actually not really going by that line of thought. And similarly is for the flap, latimus dorsi, and this and that, whatever you are going to put there. That's my submission number one. So yes, you would probably not. I mean, who has studied that sort of cosmesis that, if you have this flap, then what is happening? If you've done that flap, then what is happening? That sort of data is not really there. At least experience is not there. So I would answer your question now that yes, for reconstruction, I would certainly never consider ultra hypofractionation in my practice. I'm not doing that study, So I'm serving the community, so I will not do it because that data is not there. Point number one. Point number two, I don't consider ultra hypofractionation for breast anyway, because that data is not mature and it has a lot of gaping holes. And yes, it is for us as a scientific community to prove that the benefit or not of that data. But when we are serving the patients, if it is not on protocol, I would not do ultra hypofractionation.
Can I just
Dr. Prekshi, ma'am, sorry, please.
No, I just wanted to reiterate the same point that even today, I would not use it outside of the protocol.
Ma'am, I wanted to ask you a question. Dr. Prekshi, can I ask one question to Dr. Punita, ma'am?
Sure, sir, sure.
Ma'am, I've always had this question about not the ultra hypofractionation, hypofractionation for breast. Since the locally advanced breast cancers were not represented well in any of the START trials, and whatever data of LABC is here and there, some Chinese data, this and that is there, how comfortable are you really treating with a multiple node positive breast cancer sort of a thing, skin involved or not, neoadjuvant given, those type of LABCs with hypofractionation, not ultra hypofractionation? No, I'm not asking that question. I'm asking 14, 15 type of data.
Yeah, so 14, 15, see now today it is such a standard of care. We've published our retrospective results. Tata has, PGI Chandigarh has. So I think that question has been answered, that 40 gray in 15 fraction is the way forward as standard of care. And that is what we need to, because one, with 40 gray, that means equivalent of 46 gray. If you've accelerated it modestly, you get as good relapse rate, as good survival outcomes, and locoregional relapse-free outcomes. And the cosmesis has not changed. In fact, if at all, it is a bit gentler on the this thing. The only thing
Is
that
the Indian data a 10-year? I'm sorry if I'm asking this question, but is the data long enough to be fully reliable? 10, 12
yes,
years long data?
I would say, except for the cardiac thing.
Yeah, sure.
That is one thing that only maybe the next decade we'll be able to answer that. But other than that, yes.
I think I also will agree with Dr. Punita that 14, 15 is now a standard of care for practically all indications. Dr. Punita, tell me one thing. For this ultra hypofractionated patients who are completing radiation in 1 week, do you position this radiation between surgery and chemotherapy, or you are still doing it after the all chemotherapy has been completed, like in other 14, 15?
Yeah, so because see, ours is a government hospital, and the constraints are far too many, and so is CMC Vellore, and at some point in time, AIMS Jajjar was also a part of this. And so we find logistics is a big issue for us, and it continues. Trial or no trial, it will always remain a big issue. So we normally, आज की तारीख में, if we look at it, तो lot of significant proportion is getting NACT followed by surgery, followed by radiotherapy. And we have to go by it. And if it is surgery, upfront surgery, then the dates are taken, and we try to synchronize it, but we cannot. We are not in that position. We don't have that luxury that we'll say, okay, ये trial का patient है, तो इसको हम जल्दी ले लेते हैं. It has to be just the way it has to be treated.
Sorry, I think I'll wrap up this session in 2 or 3 minutes. Dr. Achal, a quick question. What is your take? Like, have you practiced ultra hypo schedule in any of your patient?
No,
And
no, I
suppose
have
you
never.
have to use, what do you think? Connective tissue disorder, does it become a contraindication for using this schedule, or is it fine to
No,
go?
I think contraindications have to be the same. Like we cannot say ultra hypofractionation, but I have no personal experience of using ultra hypofractionation in any of my patients.
Okay, right. So the questions are many, but we need to move on to our next talk, which will be followed by a discussion of the topic. For the talk, slides please, Neerav. For the talk, I would like to invite Dr. Kanu Charan Petro. Neerav, can I see the slides, please? Dr. Kanu is Clinical Director and Head of the Department, Radiation Oncology at MGCH RI, Vishakhapatnam. So yes, your slides are visible. Yeah. So Dr. Kanu, we welcome you, and I invite you for the talk, Tumor Motion Management in Breast Cancer.
Just I'm sharing my slides.
Yeah, sure.
Okay, is it visible?
Yes, yes, it is visible.
Okay. So I will tell about the motion management in breast cancer, and in the what is the quantum of benefit doing in this motion management in the breast cancer. So if you in this my few minutes presentation, I'm going to tell about the why there is a need of motion management, how to tackle the types of motion management, what are the types, what is the quantum of benefit. So if you see during the inspiration, the diaphragm goes down, and there is increase in the anteroposterior distance of the chest thoracic cavity. But during expiration, the anteroposterior distance is decreases and diaphragm goes up. If you see in the pictorial diagram, there is a distance between the anterior chest wall and the cardiac increases. Here in the expiration, it is the distance between the cardiac and chest wall decreases. In inspiration, it increases. So if you see in this diagram, if you see that doing the tangential field also, if you do the DIBH, but deep inspiratory breath hold, so there is a high sparing of the cardiac area, and there is a good benefit with a cardiac chest wall separation, and we can able to decrease the mean dose to the cardiac and the under descending artery. In this two scans here overlapping, if you during the normal respiration, the distance is the 1.22 centimeter between the anterior chest wall and the cardiac. And if you do the deep inspiration, there is an increase in 1 centimeter. It is a 2.62 centimeter. So definitely there is a, if you even if you treat in the tangential field with DIBH also, there is going to be very much beneficial to decrease the dose to the cardiac in long run, because breast cancer patients, they live long, like 10 years, 20 years, where the cardiac morbidity will be less. So in the simulation, you can do the normal breastboard or with breastboard with mask, even breastboard with mask. Or if you don't want to do anything, you can simple back lock also in this position you can do. And if you have your linear accelerator is getting having the hexapod couch, that will also be more beneficial and helping the correction of the rotational errors. So what are the options available? If in the doing this motion for the handling the motion management, we have a voluntary breath hold, ABC, active breath coordinator, RPM, real-time positioning management, surface guided radiotherapy, that is a video camera based radiotherapy. So those patients, those having those don't have the motion management system in their department, they can ask the patient to the voluntarily breath hold, and we can control with the switch on and switch on the beam and switch of the beam by through electrical switch. But it is a very crude way of management, where and the usually if you are very obsessed you are very obsessed to having the DI-based system, even you don't have a motion management system, you can do this voluntary breath hold mechanism, and you have to we can control from the console and to the treatment couch by mouthpiece or speaker, so that you can so when there is a patient is in breath hold, you would start on the beam. When there is a patient is not on the breath hold, and just switch up the beam. So it requires more training and patient counseling before doing this treatment. Best thing is the Electra ABC system. It is known as a active breath coordinator. Based on the breath hold, during the breath hold, the treatment will go and works like a spirometry. No, needs good lung function. If the patient don't have a good lung function, we can this system does not fits good, but at least 20 seconds or 30 seconds of breath hold is important. So how it works, the patient breath holding system, so how it works. So this is called nose piece and mouthpiece. Patient asked to go for a 5 days training before starting the treatment, and patient is asked to do the breath hold. Patient can visualize where is the breath hold. So it is a normal respiration, and we will ask the patient to do the breath hold, and during the breath hold, the patient treatment will go on, and after 30 seconds or according to the 40 seconds, according to the patient's capacity, lung capacity, the patient 30 to 40 seconds, you have to fix the green line between 1 liter to 2 liter according to the patient's lung capacity. And during that horizontal line only, you have to treat, beam will get switched on. It is not sync directly, but you have to do something voluntarily. So when the patient is doing the respiration in the with the patient should breath hold in this line, that line only you have to treat. Another technique is called Varian RPM, real-time positioning management, and it is based on the amplitude based. So how much chest expansion happens, and accordingly you have to do. So this is the thing what again we have to treat the real-time positioning management. Here the patient moves up and down, but so there will be a detector, external detector. That detector is carried forward by the captured by the infrared camera and automatic sync of the beam on. So if you see the patients, this is the external surrogate, this is the infrared camera, and when patient holds the breath, the external surrogate and the infrared camera and beam it's sync, and that time only go for the treatment. So this is those having variant system, they can do the DIBH in this technique. And another technique, another very popular nowadays is camera based gating, where the this is called surface guided RT, either vision RT or catalyst surface guided RT. In these two conditions, what happens? Patient have the system takes the various pixels of the body and it creates a if patient moves beyond the specified distance out of the position, or if any abnormal breathing occurs, the radiation beam can be held automatically. It is no marker is required, no physical marker, no box, no belt, no nothing. And it is a very non-invasive, non-ionizing radiation. So in this technique, when the patient expansion happens, particular period, then the beam only the beam sink open happens. So this is also surface guided RT and gate RT. So all these systems are now the very much popular all over the institutions. Either you may have a Electa, you will have a ABC. If you don't have a Varian, you will have a RPM. And surface guided RT is a third party, and you can go for the do that. You can acquire this third party system also. You can invest in Electa or Varian as per your need. So whether there is a benefit, what are the quantum of benefit? Whether there is a benefit doing all these things? Yes, let's see. So despite improvement in the radiation techniques, radiation-induced cardiac dysfunction occur in those with thoracic cancers. Newer studies have examined associated between the cardiac substrate doses and cardiac outcomes and survival. Advanced cardiac imaging allows to assess the regional dysfunction after cardiac radiation exposure. Enhanced dose tracking, imaging, comprehensive clinical data hold promise the personalized report to minimize the cardiac toxicity. So the radiation toxicity happens in the lymphoma, breast, lung, esophagus, and thymomas. So if you see radiation-induced heart dysfunction, either may be pericarditis, conduction abnormality, myocardial fibrosis, myocardial ischemia, myocardial microvascular disease, dysfunctional valve, and coronary artery disease. So either coronary disease, pericarditis, valvular dysfunction, arrhythmia, and heart failure. So if you vascular toxicity, you see that a porcelain aorta, coronary artery disease, autonomic dysfunction in valvular aortic mitral valve disease, regurgitation is more than stenosis, cardiac arrhythmias, and electrophysiological deficiencies, pericardial diffusion, and constrictive pericarditis. Apart from that, either pre-existing cardiovascular disease, cardiovascular risk factors, concomitant chemotherapy, inadequate shielding, presence of tumor in the next to the heart, high dose radiation, younger age, high cumulative dose of radiation, and chest wall radiation. All these factors affecting the radiation-induced heart disease. So most credit goes to Sarah Darby, who has done the many studies and many publications. So what is the risk? So risk of ischemia heart disease in women and after radiotherapy breast cancer. So if you see, if there is a increase in a single gray of the mean heart dose, there is a 7.4% risk of the cardiac events. So the overall average of mean dose to the whole heart is 4.9 gray. The rates of major coronary artery increased linearly with the mean dose to the heart by 7.4% per increasing the gray. With no apparent threshold, the threshold increase started in the first 5 years after the radiotherapy. Proportional increase in the rate of major coronary artery per gray was similar in women with a cardiac risk. Exposure to the heart to ionizing radiation during radiotherapy for breast increases the subsequent rate of ischemic heart disease. So again, there is a study by coronary artery disease in young women after radiation therapy breast cancer. This is study is called WeCare study. That study told that young women treated with RT for left-sided breast cancer had twice the risk of coronary artery disease compared to treated for the right-sided breast cancer. So literally, the radiation is independently associated with increased risk of coronary artery disease should be considered in survivorship and young breast cancer patients. So there are very many data are there, many studies, and there is what are the coronary events and what is the conclusion dose constant they have given. I will go by one. So what is the radiation-induced heart disease? So fibrosis, calcification of the aortic root and aortomitral curtain that lead to the progressive stenosis and aortic mitral valves. Osteal-corollary stenosis, myocardial atrophy, and widespread pericardial adhesions thickening automatically lead to the intractable and inoperable pericardial constriction. So what happens in if there is a, this is called clotting cascade. In acute inflammation, there is a immune cells recruitment, release of pro-inflammatory mediators and the interleukins in that area. Slowly, chronic inflammation, platelet divided growth factor, TGF beta, all these things that help in the fibroblast formation over the after radiation from minutes to months. So age-related atherosclerosis lead to coronary artery disease and decades of post-RT lead to reduced flow to the myocardium and reduced capillary density, reduce the collateral, combined cause the myocardial ischemia. So if you see, this is a patient of 16-year-old boy who was treated with 40 gray to the radiotherapy and Hodgkin's disease. You can see how the vascular is getting blocked with radiation after the age-related atherosclerosis. So in the pericardium, this is the normal pericardium. Over the years, this pericardium is getting fibrosed over the years during the survivorship. The myocardial changes that causes more fibrosis, the fatal diffuse myocardial fibrosis several years after radiation for the Hodgkin's disease. So how to identify the things? You can do the perfusion scan or SPECT scan, where you can see the patient before radiation and after radiation. You can see the new defect here, the perfusion defect. So the manifestations may be acute pericarditis, pericardial effusion, constrictive pericarditis, cardiomyopathy, ischemic heart disease, valvular regurgitation, stenosis, cardiac arrhythmia. And according to the problems, the patient will have many symptoms, and you have the investigations and the management required. So in these situations, we have to help of the cardiologist. We have to do the many some medication to surgical intervention. So in the contact data, the contact recommended that volume of blood receiving greater than or equal to 30 gray should be kept below 46%. Mean heart dose less than should be kept at 15 gray. So first time the risk of myocardial infarction, coronary revascularization or death in breast cancer survivors increases a linear relationship with the cardiac radiation dose. The rate of MACE increased 7% per 1 gray increase in the mean heart dose in the patients. So if only DIVH is not important, out on the DIVH, you have to see the contour of the left coronary artery, left anterior descending artery, circumflex coronary artery, right coronary artery. And according how to do the contouring, all those things, you can go through this article published in the Green Journal 2017. So by Francis. So you can do the contouring, and if you want to more do the more studies, you can do the plan and do the planning implementations. Mostly when the constraints, we keep the heart dose, mean heart dose should kept less than 2.5 gray, left ventricle, and not only contouring the heart is sufficient. You can contour the all chambers, all valves, and coronary arteries, though it is a very difficult. You can values we can put inside the things, keeping the dose at you can follow these guidelines. So there are many recommendations, screening recommendations for the by ASCO, Children's Oncology Group and ISMO group. What to do or when to what should be done. So if you follow the ISMO guideline, cardiac check should be start from 6 to 12 months after the radiation therapy. Then after possibly periodically thereafter. Evaluation of coronary artery disease and ischemic starting at 5 years after RT, and then every 3 to 5 years after. So you can follow any guideline according to your convenience, and you can practice. There is a cardiology society they have given. If medicinal RT, RT more than 30 gray, less RT 30 gray, age less than 50%, higher if you are practicing hypofractionation, presence of like a breast cancer, cardiovascular risk factor, pre-existing cardiovascular disease, you have to total thoracic examination every 6 to 12 months, and all patients should have by 5 years after 5 years of RT, you should do the proper coronary artery disease evaluation and ischemic evaluation for all patients. There are many technologies, echocardiography, cardiac MRI, cardiovascular tomography, stress spec. They have many limitations and strengths of various things. but at least we should take the help of the cardiologist to do the perfusion scan or something, any cardiac equivalent 2D echo scan. The minimum is 2D echo to the specs scans according to the need of presentation, patient symptoms, and we should take care of the. There is no recommendation what to do and not to do. If you some other things also, apart from the DIBH, we have a protons, we have a supine breast radiation, we have a APBI, partial breast irradiations, and we can plan also. So there is a DEGRO guideline how to do the heart sparing technique for breast cancer patients. So DIBH represents the best explored cardiac sparing method, consistently showing a significant advantage of heart sparing in breast cancer patients. Apart from that, you can practice APBI, you can practice IMRT or volumetric. And if you if you do the DIBH and IMRT, the seems feasible. There are very few large studies in the topic, and you can plan both the systems. Cardiac sparing techniques, apart from the 3D CRT, IMRT, proton, electron, prone positioning, many things are there. So according to convenient, you can do. So this is, as you know, deep inspiratory breath hold. We can able to spare the cardiac doctors. Another thing I am, this trial showed that the studies for data when DIBH during left breast radiation, DIBH reduced the mean heart rate by up to 3.4 gray when compared to the free breathing. So DIBH is a more reproducible, stable technique, and you can decrease the dose. So if you see these various studies, free breathing and DIBH, if you do the cardiac mean heart dose, it is decreased radiation doses around 40 to 60% in many studies. Even same you correlate with the DIBH in the free breathing and DIBH breathing, the left under and descending coronary artery. That also we can decrease the dose by DIBH planning. Another things, those are the thing, whole heart, left ventricle, under descending mean heart dose and DIBH. So without compromising the PTB coverage and CTB coverage, you can decrease the dose to the by around 3.6 gray. You can see 3.6 gray in compared to the free breathing and normal. So if you suppose a patient is presenting with liver mets or lung mets and presenting the simultaneously you want to go for a oligometastatic treatment, so you can also use the motion management technique. This is our publication. You can go through it. So with how to handle the complex process, treating the both at the simultaneous by DIBH with breast as well as the liver or lung metastasis. So in summary, we have to adapt the technology, definitely improve the therapeutic ratio. DIBH is established technique, cardiac sparing to be practiced whenever the possible in the if you are treating the left sided heart. In conclusion, thoracic radiotherapy is known to cause a variety of cardiac damage through the inflammatory pathways. We who typically have multiple comorbidities are at a higher risk of cardiac events and early mortality after thoracic radiotherapy. Evaluation with echocardiography, electrophysiology, cardiac perfusion studies are not the part of the routine assessment for a patient with breast and lung cancer. There is a need of high quality prospective research to investigate. So what are the follow-up procedures, which technique we have to follow, whether 2D or physiological studies or perfusion studies. There is a no such guideline, but over the years we hope we can get it. Thank you very much. Wish you good heart. Thank you.
Thank you, Dr. Kanu. Great slides and a wonderful presentation. So now I invite Dr. Babita to carry forward the discussion part related to this topic. She is Senior Consultant, Radiation Oncology at Andromeda Hospital. Dr. Kanu, please stay for this
Thank you, Dr.
discussion
Prekshi.
part.
Thank you, Dr. Prekshi. And thank you, Dr. Kanu, for a very crisp and to the point presentation.
Yeah,
I would
thank
be
you.
carrying forward the discussion with a case-based scenario. And I request Dr. Kanu, Dr. Sweetie ma'am, to please switch on their videos. Okay. It is a clinical scenario. A 53-year-old female patient, performance status 1, hypertensive, diabetic. She initially presented with a locally advanced left breast cancer, 5 into 6 centimeter lump, upper inner quadrant, overlying skin is involved, nipple areola is free, with multiple palpable axillary lymph nodes. She underwent a PET CT, which showed a 6 into 6 centimeter lesion, upper inner quadrant. Skin is involved. It is abutting the pectoral muscles. Shows multiple axillary lymph nodes, largest 2 into 2 centimeter. And there is an internal mammary node, the second intercostal space, 1.5 into 1 centimeter. A biopsy was done, which showed invasive carcinoma and grade 2, ERPR positive, HER2 negative. She underwent neoadjuvant chemotherapy, 4 cycles of AC followed by 4 cycles of taxane. And after chemotherapy, the PET showed residual disease, 2.7 to 5.7 to 3.2 centimeter lesion, upper inner quadrant, mild decrease in avidity. The axillary nodes as well as the internal mammary node previously shown does not show any uptake. The patient has undergone an MRM. The post-op report shows that tumor is 3 into 1.5 into 2.5 centimeters. Upper inner quadrant, grade 1, skin is still involved. The margins have all come out to be free. Axilla, 1 out of 9 lymph nodes is involved. There is no extracapsular extension. Now the patient has been referred to us for radiation planning. So my question to you, Dr. Kanu, would you consider this patient for DIBH? Her breath hold is approximately 20 seconds and the patient has not undergone any training right now. It's a first visit to the OPD.
Ma'am? Hello? Hello?
Hello.
What is the question?
Hello. I hope you could hear my question.
Yes,
My
ma'am.
question is, would you consider this patient for DIBH? Her
Yeah.
breath hold approximately is 20 seconds.
Okay, no problem. So
All right.
if it is a 20 seconds, not any issue, you can plan with at least by tangential. Tangential methods of treating is hardly 3, 4, 5 breath holds. But if you plan with the IMRT or VMAT or something, it takes more time. If slightly less breath hold, you can take the conventional 3D plan also sufficient.
Right. Dr. Sweetie, ma'am, what target volumes would be, you would like to consider in this case? You're on mute, ma'am.
So patient was clinically T4B lesion earlier, which has responded to chemotherapy.
Yes,
so she is the T4B lesion, which has responded to chemo. So my target will be chest wall, the IMN, internal mammary regional, and the supraclavicular region. Axilla, I won't take because there is no extranodal extension and 1 out of 9 nodes are positive only.
You will be comfortable planning this case where internal mammary node is positive with DIBH?
Pardon?
I'm saying you'll be comfortable planning this case with a DIBH. Patient has internal mammary lymph nodes, and when we are planning with the simple tangents, then the lung dose and heart dose tends to come out slightly higher than the routine planning that we do for DIBH.
Yeah.
Since the node has completely responded to medical treatment, neoadjuvant chemotherapy, you would still like to consider treating it with
yeah, I will like to
taking it up for
consider it
radiation.
treating. Yeah, I will like to consider it still in my target volume. As of now, we are not treating by DIBH. Okay, we are not routinely using, because being a high volume center, it's difficult for us to take such patients for DIBH and all. So but still consider this patient for this. IMN will be included in my target volume.
Dr. Kanu, do you
Yes,
agree?
ma'am. Yes, ma'am. What is the question?
So the question is, would you consider internal mammary region also in the target
Yes,
volume
ma'am.
in this case?
Usually in the advanced disease and if you are giving NSCT or you have axillary burden is high, I definitely treat the internal mammary node. And we should not worry for the treating internal mammary node because the cardiac dose will increase. So if you see we are treating with the upper 3 or 4 side intercostal spaces. So that area is heart is not there. But when you are treating with three-dimensional technique, 3D tangential, definitely there is a cardiac dose will increase. But if you treat with the any higher technique, I don't think it is the cardiac dose will increase. and we have to address with DIBH, it is great.
In your experience, sir, doesn't the lung dose also increase with this once you're covering IMC with the tangent?
Slightly may increase, but if there is an internal mammary failure, that is a big disaster rather than a lung small fibrosis.
Agreed. What is your preference to plan such cases with a 3D CRT technique or VMAT or IMRT combined with DIBH?
So if your physicist is very comfortable with the plan VMAT, do it. If not comfortable, at least 3D CRT tangential is sufficient. But the thing is that when you have to treat with the VMAT and everything, you should keep the long dose V5, V20, V10 by V20 at least 20 between 25 and V10 is at least below 40 and V5 below 60. You have to keep it properly. Otherwise, there will be a high chance of pneumonitis.
Okay. Would you consider DIBH would also for patients who have undergone VCS with a silicone implant or a graft placement?
Madam.
Would you also consider DIBH if this patient had undergone BCS or had a graft placement or a silicone
No,
implant?
that is not going to change the treatment policy. Maybe target delineation may be different, but both cases you can plan DIBH also.
Dr. Kanu, can I ask a question?
Right.
Yes, sir. Yes, sir.
Yeah. Do you find any challenges when you are treating patients with DIBH? Any particular caution you would like to recommend to our colleagues?
The caution means the main thing is you are planning for the DIBH when you are going for the delivery treatment delivery, when the matching with the sternum to sternum match you have to do properly. The clip box should be in the sternum to sternum match, not the spine match. So that caution should be properly to be done. Second thing, when you are DIBH, train the patients properly, and at least if your patient is properly 20-30 seconds in taking adequately, go for VMAT or something. If you are not, they have to at least plan for the tangential.
And do you find any challenges in the last week of the treatment? The patient might be tired or having some esophagitis or some other problems by the third week?
No, sir, Ethan, not such problems we face actually.
Okay.
We are practicing since last 5 years.
Yeah.
Dr. Sweetie, ma'am, any differences in acute or acute reactions, skin reactions, esophagitis and all seen in DIBH versus the conventional planning in your experience?
Actually, I think Dr. Kanu will be a better person to answer this because I do not have actually real personal experience in treating with DIBH.
I don't think it is a issue with DIBH by treating with skin doses and everything are almost normal. Nothing to be worried for the either you treating DIBH or normal thing.
So do you consider simultaneous integrated boost also with DIBH?
We don't practice SIV technique, but we just go for sequential boost.
Okay.
That is not going to hamper your whether you are practicing DIBH or not DIBH. The technique is same. And if you are,
So, but then you'll have to plan with ARC or IMRT if you're doing.
If you have a SIV technique,
then the planning becomes more complicated.
If you have a SIV technique or something, you can do that time only. You have to giving more fractionation. That time you should better to do the DIBH rather than only without DIBH.
So, which cases you would not consider for DIBH?
So all left-sided breast can be treated with DIBH because the thing is that when we are evaluating the patients for the coming 5 years, that after 5 years either doctor will be not there or patient will be going to somewhere. So we have not evaluating the proper things in a cardiac evaluation, not doing after 5 years, and so we don't know what happens in the late reactions and things. So better to practice DIBH and implement in the department.
Right,
Dr.
right.
Kanu, sir, I have one question for you, sir.
Yes, ma'am.
So for right-sided breast cancers, would you advise the DIBH for these patients also?
Some people feel that we can spare some extra long. I don't think right side of breast is required for the DIBH. I don't think so. And it is needed really.
And for bilateral breast, suppose, does DIBH play a role?
Better to do. If you are
So
practicing.
sequential, you treat one left side with DIBH followed by other side without DIBH.
So, ma'am, actually, if you are practicing the bilateral breast, it is a very tricky, and we don't know if you sequentially, if one breast followed by another breast, if you treat, we don't know hotspots, what is happening. So
Exactly.
always, if you are treat both at once, and you ask
Yeah.
your physicist to see the hotspots where it is going. Otherwise, you will get more fibrosis and more problems.
That's what we do. But actually, I was asking, so if it is a bilateral breast and we are doing it simultaneously, so does the patient comply to following this DIBH protocol, and is she comfortable? Because
Yes,
the treatment time will increase.
If lung function is in okay, no problem. At least you can plan. If there a patient is not able to take the proper breath hold is less time, you can practice to 2D take. The tangential technique is also equally good comparing to the VMATs and everything.
Right.
Okay. So one last question. Earlier we were having a discussion about ultra hypofractionation. So what would be your take to, combine ultra hypofractionation with the IBH for left-sided breast cancer?
So one sentence I have told in my presentations: when you are practicing ultra hypofractionation schedules in the left side, you can go for the follow the dose constraints. And we have a publication from the ultra hypofractionation in the 5-fraction schedule, and very difficult to get the achieve the cardiac dose. And if you put in the DIBS, definitely it will help to get the proper less cardiac dose. So I suggest whenever you go for the ultra hypofractionation schedules and hypofractionations, better go for the DIBS technique.
Right. Thank you so much, sir. Back to you, Dr. Prekshe.
Yeah, thank you, speakers, moderators, and panelists. To give the vote of thanks, I will now like to invite Dr. Vaishali Zamre, ma'am. She is Director, Breast Oncology at Andromeda Hospital, Sonipat. What do you, ma'am?
Thank you, Dr. Prekshe. So that was a great webinar today we had. For that, I would like to really thank Dr. Punita Lal ma'am and Dr. Kanu Charan Patro sir for such lucid presentations. Not only did they make the topic easy for the budding radiation oncologists to understand, but also for us breast surgeons also. So thank you so much for that. My thanks also goes to Dr. Sweetie Gupta, Dr. Gagan Saini, and Dr. Achal Agarwal for joining us as panelists and making this webinar a really interactive, learning experience. I would also like to thank our audience who are our constant inspiration for making this webinar series come so far. So we've completed 35 webinars so far, and that your presence, your constant presence with us also gives us a lot of inspiration to keep going. And we would soon come up with a new webinar. That is our promise. I would also like to thank our senior colleagues, Dr. Arun Goel sir, Dr. Rajiv Agarwal, Dr. Dinesh Singh sir for giving us, different ideas and helping us organize these webinars. And obviously, MICE Ideas, the entire team has been with us for many webinars and help us organize and execute these, events seamlessly. So with that, I would say thank you once again to all of you who is, and of course, the moderators, how could I forget them, Dr. Prekshi and Dr. Babita, thank you so much for taking this panel discussion, very smoothly. With this, with the promise of a new webinar coming up soon, I would like to say very, good evening and good night to all of you. Hope to see you all soon again. Thank you.